monitoring in the operating room. Again, because we have this long history of a relational database, we didn't necessarily know back in 2000 that colorectal surgery would be a point of emphasis for CMS and other agencies. But because we were collecting information on all of our patients and we were collecting it continuously, we were able to retrospectively look at our data. We were able to identify where we could make improvements, and pretty quickly we were able to achieve pretty significant improvement in the area of temperature management in our colorectal surgery patients. This is just a different way to represent that. What we've done in this graph is put the benchmarks in so that it's very quick and easy for someone to see that, you know, by 2008, really, we were meeting that benchmark very consistently. And finally, you know, as I suggested earlier, and I think it was obvious from the last slides I showed you, statistical analysis is not imperative. However, there will be occasions where you want to use statistical analysis. In this situation, we applied a control chart to our high-risk temperature trend, and you know, can clearly demonstrate with a degree of statistical significance that we were able to improve the care of our patients. This is just a graphic representation of the range of observations here that we use to monitor. I don't want to get into the detail of this slide other than to give you an impression of the number of things that we actually monitor on a continuous basis. This is the observations that we use in the recovery area, and again, you can see that it's fairly extensive. It's not difficult for us to do this, and again, as I said, you know, we have well over 90% compliance with all the data elements that we ask our providers to enter. One other element of how we evaluate the information we receive, in addition to looking at graphic trends, we've assigned observation reviewers. These are providers in my practice who receive the charts of any patient who is indicated to have one of these observations, and they qualitatively review the charts to see if there's any significant trend that they might observe in a qualitative fashion. Other ways that we use the information is outcome mining. What I mean by that is we look at the data and identify subsets for improvement. We typically do that by sorting it by a particular outcome or some type of case criteria. One example of this is the recovery room nurses at one of our sites of service asked if there was any particular subset of patients who experienced significant pain that they could focus on to improve their pain management. They didn't want to just generally apply to all their patients, but they wanted to focus on one specific subset. So we ran a query of our quality assurance data asking what the VAS, average VAS scores were, which you see on the y-axis here, and compare that to the CPT codes on the x-axis. And what we realized, and what was fairly surprising to them, is that, you know, tonsils and adenoids were a fairly significant representation of the more painful end of the spectrum. That surprised the nurses, but it did allow them to focus on the tonsils and adenoids, and they've developed a program that we're continuously monitoring, and hopefully in the next year or two I'll be able to come back and show you that we were able to improve those results. But it was powerful in many different ways. Number one, obviously we were able to identify a subset of patients that were experiencing significant pain, and hopefully we'll improve that. But number two, it gave me an opportunity to give information back to the nurses. And that was useful because now they're looking to us to provide them information on how to guide their practice. And so that gives them the impression that we are very useful and we are very significant in helping that hospital's practice. Other ways that we use the information, we do factor reviews. What I mean by that is we identify related variables to the outcomes that we're measuring. We attempt to make changes and evaluate the responses to those, and we also compare ourselves to the literature. This is an example of a factor review. We were following our trends for reintubation rates. I think we observed in 2002 that possibly there was an increase in rate of reintubations, again because it's a busy clinical practice and we don't consistently apply statistical analysis to this. We weren't sure, but certainly by 2003 I think it was fairly obvious to us that maybe there was something going on. It was worth our while to look at this in greater detail, so we did sit down and think about what had happened in our practice over this time. One of the things that we recognized is that we had introduced rocuronium to our practice in 2001. We evaluated our utilization of rocuronium. It seemed to mirror this trend in the rise in reintubation rates. We developed a hypothesis that maybe rocuronium was involved in this trend. So we advised our providers to that possibility, and also at the same time we removed rocuronium from the carts. We didn't make it completely unavailable. You simply had to leave the room to go get it. Obviously, just like anybody's practice, that reduced the use of rocuronium rather dramatically, and I think at least in our situation it probably played a role in the reduction of reintubation rates, which we continue to follow, and I think have stayed significantly lower than they were at least in 2003, as has our rocuronium use. Whenever we do a retrospective review like that, we like to compare it to the literature to see if there's any additional guidance, one, to tell us why this might be happening, or two, to tell us are we even in the range of concern. Hopefully in the future we'll have registries that we can use to compare ourselves to, such as AQI, ABG, SAMBA, and there are other specialty groups that are developing registries that we can all participate in. One of the articles that we were able to reference more recently, obviously, was the journal Clinical Anesthesia. It too was a retrospective review of quality assurance data, and as you can see, remarkably, their rate of reintubation events was pretty similar, at least on the same order of magnitude of our rate of reintubation events. So that gave us some feeling of comfort that our system was fairly reliable, and it was consistent with what other providers were finding across the country. This is an example of using the information on our acute pain service. I think in 2005 we felt we wanted to improve the rate of epidural catheter displacements on the floor. So what we did is developed a specific way of taping it. We call it framing. I won't get into the details of that. But once we introduced that notion, we felt like we had made a significant improvement in the rate of displacements. It dropped from somewhere just below 9% to just below 6%. We think that might have been a meaningful drop. But then the very next year, it went well back up above 9%. Now, maybe the original drop was really nothing more than an aberration, and really there was never any real significant change. But we did also realize that in 2007 we had changed to chlorhexidine PrEP, which was different than our betadine PrEP, and we didn't really have to wait quite as long for it to dry to be effective, and so I think providers weren't waiting, and we were applying our tape to a wet back, if you will. So we had educated all our providers, let them know that we needed to dry the area, not just put the tape on while it was still wet. And I think, again, we were able to reduce our rate of displacements, and hopefully once we get the information from 2010 back, I can show you that we're still down lower and that that was a real meaningful and significant change to our practice. Recently, I don't know if this occurred in your practice, but we were confronted, if you will, by our orthopedic colleagues who had been reading busily in the noted New York Times medical journal in the business section, where the inventor of the bear hugger device had come out and stated that although he invented the bear hugger device, he never intended it to be used in hip and joint replacements, and that it may lead to increased rates of infection. He, by the way, has a nice, easy alternative for you if you want to buy his newer product. But suffice to say, our orthopedic surgeons, after reading that, became alarmed and concerned that we were putting their patients at risk by using the bear hugger device. So we went back to the information that we had available to us, and the first thing that we wanted to demonstrate today and ourselves was there a significant impact of temperature on our patients? And I think it's fairly clear that if you look at the temperature of patients who did not have an infection, the no group, their average temperature was close to 36.4. If you look at all the patients, and this is about 100 patients who had infections, their rate of infection was, their temperature was closer to 36 degrees. So I think clearly, you know, in our practice, just like anybody's practice, temperature does have an impact on the rate of perioperative infections. Now, but the greater question and the more specific question was, so does bear hugger use itself have any influence on the rate of infections? Because there are other ways to manage temperature. And we were able to look at the rate of bear hugger application, and you can see that when we utilize bear huggers, our rate of infections is something just above 0.8%. When we don't use a bear hugger, it's slightly higher. I'm not convinced that I would say that this is a statistically significant difference, but I do feel confident in telling my surgical colleagues, at least at this time, we're not putting our patients at harm using a bear hugger, and that before we change our practice in any significant manner, we should wait till there's a more elegant study than a New York Times business section article. This was another example of a challenge to us from our orthopedic colleagues. They became aware of a recent article in anesthesiology from Taiwan that suggested possibly general anesthesia might have a greater risk of infection than spinal anesthesia for patients undergoing total hip and knee replacements. We certainly had a long experience. This is about 9 years worth of data, several thousand patients utilizing both general and spinal anesthesia. Our use of general and spinal anesthesia, probably just like everybody's, varies due to the bias of our practice at the time, and right now we do a lot more general anesthesia with regional blocks than spinal anesthesia. But I think overall, as you